So, good evening, one and all. We are all present here. I am Harsha here from Science Integra, and I welcome you all for the 15th webinar of Maha Smiles Cleft Care for Every Child. I would like to introduce to Ms. Charvi ma'am, who is the Program Officer of Smile Train India. Over to you, ma'am.
Thank you, Harsha. So, before I start, I'll briefly tell about Smile Train. As many of you must have heard about it, Smile Train is world's largest cleft-focused NGO, and over the last 24 to 25 years in India, we have completed almost more than 7 lakh surgeries, all free of cost. 100% free of cost cleft surgeries. This Maha Smiles.
हेलो अलका दी फोन कर रहे हैं तुरंत
Yes, you can continue.
हाँ अलका दी
Mute
Yeah.
yourself.
Somebody's, yeah. So Maha Smiles program, which has been initiative started by Smile Train in collaboration with Bajaj Finserv, is a particular initiative specifically for the state of Maharashtra. Can you share the screen, Harsha?
Sure, ma'am. Ma'am, if you can share your screen of that PPT which you have to present, you can do with that.
Okay, so you have
Introduction.
CVs. Okay.
Yes,
So
yes.
no worries. Okay, no worries. I'll go ahead. So
Okay.
Maha Smiles is a flagship CSR collaboration between Bajaj Finserv and Smile Train to build awareness and support treatment for children with cleft in Maharashtra. And Maha Smiles will enable nearly 8,000 life-transforming cleft surgeries of children in Maharashtra over a period of 36 months. So the aim is to create awareness about the importance of timely treatment and timeliness of cleft treatment, and to build a referral network so that children can avail care from birth itself. So I would like to also mention that Smile Train has free toll-free cleft helpline number 1800-103-8301. So please refer children and parents in need to Smile Train India. I would like to now introduce Dr. Monica and Dr. Supriya. Please show me the CV, Harsha. So Dr. Monica is a consultant gynecologist at Mangalya Nursing Home and Atharva Fertility Center.
Charlie ma'am, that should be enough because we have our esteemed guests waiting.
Sure.
So let's. I just wanted to let them know that Dr. Supriya and I are the coordinators for this program, which has been since the last 15 months. The first 12 programs were coordinated by Dr. Rashmi Kahar madam and Dr. Sujit Konkar. And from the last 3 months, both of us are doing it. Ma'am, it is an honor to have you with us to know the amount of work that you have been doing through the Smile Train project. And it is always good to associate with AMOX as well as the Foxy body. So we have today our chief guest, Dr. Sunita Tandurkar madam, none other than the president-elect for the next year. We welcome you, ma'am. Madam has been the head of the department of and chief of IVF endoscopy center at the Ruby Hall Clinic, Pune. She is the president-elect Foxy. She has been the advisor and consultant at Dr. D.Y. Patil IVF and Endoscopy Center, Pune. She is the founder and director of Solo Clinic IVF. She is also the founder and medical director of Solo Stem Cell Clinic. And she has an extraordinary achievement of the India's first stem cell baby with the world's first at the age of 45 on the 16th of April 2018. She has been the past president of the Pune OBGYN Society. Ma'am, it is always an honor to have you with us. We welcome you for your words of wisdom.
Thank you. Thank you, dear. Thank you so much. Can we close down this slide of mine?
Harsha, please stop sharing.
Stop sharing. It's lovely to see you all. And Monica, most active lady. Thank you for having me as your chief guest. This is Smile Train. Charvi, lovely to meet you back. I met you on a Zoom platform. And wonderful projects and wonderful work. you all are doing. And I know, I think in our meeting also, I spoke to you, Dr. Srirang Pandit. I think after years, I'm seeing him here. We have a connection. We used to, I don't know about Dr. Pandit anymore, but I don't work now in Pune Hospital where Smile Trend program goes very aggressively in Maharashtra. And I think credit goes to Dr. Pandit and other plastic surgeons of Pune Hospital. But I think by this, we are bringing the awareness among the gynecologists, not only for identification during pregnancy. I feel we as a gynecologist can play a very important role for a prevention of it. So preconceptional folic acid or preconceptional supplements, if we give a little 2 minutes more to our patient all the time, irrespective of every lady walking in, whether she's planning or not, because 40, 50-year lady also coming to my cabin for hysterectomy, she also must be having a daughter or a daughter-in-law who is probably planning the pregnancy. So even in my Foxy presidential year, I am doing a project called Sampurna, Swastha Janma Abhiyan. Every pregnancy has to be a pre-planned pregnancy. So we avoid a lot of maternal and neonatal morbidities and mortalities both. So, Charvi, once again for a Smile Trend, I don't know what is happening with the Foxy projects, but I'm very sure that in Maharashtra you are working very well, and the plastic surgeons and the gynecologists are supporting alike. So let's work across the country. Cleft lip doesn't happen only in Maharashtra. Maharashtra gynecologists are more aware of preconceptional counseling. So probably we should capture other states as well. Thank you so much. And I can see so many friends of mine. Apart from Monica, I can see Vinita, my lovely friend, and who probably will become a vice president soon. Supriya, who wants to enter in a Foxy. Sudesh here again entering in Foxy. Dr. Bharat Pawar. Jagruti, you are doing amazing work, I'm aware. Pooja keeps on talking about you. And Dr. Srirang Pandit,
Hi,
sir,
hi.
how are you?
Hi, how are you, Sunita?
Lovely, fantastic, sir.
Good to see you
Lovely
after a
to
long
meet
time.
you. You know, when I saw this, I said it will be my
Pleasure.
pleasure to be with you, sir, today and give my love and regards to
Absolutely,
madam as
absolutely.
well. We
Thank
have a
you
huge
so much.
connection for 10, 15 years. We worked in one institute before I moved on completely to Ruby Hall.
We miss you.
Yes, sir. But I also miss Pune Hospital and our
Yes.
atmosphere and a group,
Yeah,
everything.
Thank you.
Thank you so much for having me. Thank you.
Thank you so
Sunita
much.
ma'am,
Yes.
before you leave, I want to say a few words for you.
या सुप्रिया, तेरे शायरी के बगैर तो मैं
ये
जा ही नहीं
बगैर तो
सकती।
शुरू नहीं होगा, वही बोल रही थी मैम।
तो आपके लिए अर्ज किया है कि आपके बारे में कहना कहाँ से शुरू करूं, खूबसूरती से करूं या अदा से करूं, आप हो इतने लाजवाब, समझ में नहीं आता तारीफ कलम से करूं या जुबा से करूं. So thank you so much for joining us, and your
Supriya,
always smiling self
I
is
will
already
always,
spreading smiles.
I always will feel कि I wish Supriya would have become a committee chairperson this year so
I
that Supriya have been
know.
working with me. But anyway, you will be working with me.
I will
Dr. Pandit
definitely.
sir, I invite entire Pune Hospital gang on 9 January. I'm taking over as a president of our Federation of OBGYN, which is one
That's
of the most vibrant organization with 46,000 plus gynecologists. And
fantastic.
I'll
Fantastic.
send my flyer and I'll come and personally invite all of you, sir.
Sure, sure. Welcome. We'll
Thank
be
you.
there. Thank you.
Thank you. Thank you.
Thank you, ma'am. Thank you, and wishing you all the best for a very, very active tenure we all know in Foxy. And we are always there with you, ma'am, for the any work that you have.
Yeah,
Thank you so
Monica,
much for.
I pick up you always. You and Supriya, the diamonds of Maharashtra.
Thank you, ma'am. Thank you so much. It's
Thank
always
you
a
so
privilege
much.
to talk to you and be in your company. You spread an aura and you always motivate everybody around, ma'am.
Thank you
Thank
so
you,
much.
ma'am.
Thank you. Thank you.
Supriya ma'am, I now request you to please introduce our guest of honor, Dr. Vinita Singh madam, as Kiran sir and Suvarna madam both are in an emergency. They will
Okay.
join as soon as they finish, ma'am.
Sure. Has Vinita ma'am joined?
Yes, Vinita ma'am is there, ma'am.
Yes.
Okay. Okay. It's indeed an honor to introduce not only our boss in Foxy, but also a very dear friend, Dr. Vinita Singh, Associate Professor, Department of OB-GYN, Patna, consultant at Care and IVF Center, presently holding the E-Zone Coordinator Foxy position, President of the Patna OBGYN Society 21-22, and more so Foxy ISUG Governing Council member. And at present, we are waiting for
Dear
her to.
Sophia, so nice to hear so many things about me. But very good evening, dear friend. And I'm really feeling very happy to be a part of this program. And thank you very much, Dr. Monica and Dr. Kiran, for making me part of this program. So I was really very happy to see my dear friend, Foxy President-elect, Dr. Sunita Tendulkar. I'm waiting eagerly for 9th when he will be becoming president of Foxy.
Harsha, please stop sharing so that we can see Madam's face completely. Yeah, thanks.
Yeah. So really, we are waiting eagerly for you, Madam, to become the president. And at the very outset, really, I would like to say that Charvi, you are doing a wonderful work, and so aggressively you are working on this and giving a smile to so many children who is suffering from cleft lip and cleft palate. So not only, as Madam has said, Dr. Sunita Tendulkar, not only Maharashtra, but it should go, spread pan-India, I think, and definitely you will be aggressively working pan-India. I think you will be giving a smile to so many, cleft lip and cleft palate children. सुप्रिया, तुम्हारे इसमें जो तुम जब भी बोलती हो, तुम्हारा जो शायरी होता है, that's really amazing. और अभी जो तुमने कहा है मैडम के लिए, that was really very good.
Thank you.
Let us give a smile to Yana children, and उस पर भी शायरी तुम्हारी होनी चाहिए. And we have two brilliant speakers as Dr. Pandit and Dr. Jagruti. I think they will be giving a brilliant talk on this subject. And I wish all the best to both speakers and all stalwarts chairpersons who will be chairing the session of this program. So once again, thank you very much, Monica, and thank you very much, Supriya, for making me part of this program. Thank you.
Thank you so much.
Thank you, ma'am. Thank you.
Thank you. So, Monica,
thank you for accepting our invitation. Yes.
And next year I'm coming. I will be, so I will be contesting for VP East Zone. So I think I need support from everyone.
We are all there for you, ma'am.
Yes, definitely.
And we also need your support, ma'am. I and Supriya, madam, are from Maharashtra.
I know, dear. Definitely. I will be there. Yeah.
Yes.
Thank you so much.
Thank you, ma'am.
Also thank Harsha and Charvi because they are doing a lot of hard work. Their team is really working hard for spreading smiles not only in children of cleft lip, cleft palate, but also the obstetric gynec community of AMOGs, and hopefully extending it to all over the country. So thank you both of you for the hard work to your entire team. Thank you so much.
Pleasure, ma'am.
Yeah.
Thank you, Harsha. Thank you, Sharmi ma'am, and thank you, the technical team, for allowing us to host this on the academic platform of Science Integra. We will now move ahead with the academic session. I would like to introduce our chairpersons for the first session today. Harsha, can we have the slides, please?
Yes, ma'am.
Yeah. Our first chairperson is Dr. Sudesh Doshi, sir. He is currently the president of the Pandharpur OBGYN Society. He is also a medical legal expert. He has been the zonal coordinator of AMOGs, and he is currently the state coordinator.
Welcome, Sudesh. Welcome, Sudesh.
Yes, sir. I can't see any the screen, please. If you can share.
Sharing has stopped. Meanwhile, I can mention that Sudesh is the boss of Pandharpur and very, very astute in as far as medical legal knowledge is concerned. He's a great asset to AMOGs, and I keep telling him and pushing him that he should move ahead now to the Foxy platform. So please do take it seriously.
Yet so humble and the most approachable person I see even in Solapur district, ma'am.
Very true.
I also invite our next chairperson, Dr. Pratibha Chavan, madam. She is the president of the Gadinglish OBGYN Society. She is a part of the Sant Gajanan Maharaj Rural Multispeciality Hospital at Mahagaon. She is a director of the Sant Gajanan Maharaj Education Group. She has had more than 40 cases of Fothergill's Manchester operation and more than 50 lap-sling surgeries for prolapse. She has a special interest in managing high-risk pregnancies at a rural setup. We welcome you, ma'am. Our next chairperson is Dr. Bharat Pawar, sir. He is a consultant obstetrician and gynecologist practicing at Anand Hospital at Malshiras. He is currently the president of the Akluj OBGY Society. We welcome all three of you to the chair the first talk by Dr. Jagruti Murke. I request Dr. Sudesh sir to please introduce our speaker.
Welcome,
And
Chauhan
Dr.
madam
Pratibha
and
Madam
Pawar sir, welcome.
Dr. Pratibha Madam would be introducing that title of the talk, and Dr. Bharat sir will can sum up this session. Can we have the slides, please, Harsha? Dr. Jagruti's. Yeah. Sudesh sir, over to you.
Yeah, thank you. It's my pleasure to introduce Dr. Jagruti Murke, one of the divas of amongst, you can say, the most beautiful lady where you see, not a very rare amongst, but a rare combination of beauty and brains, both looking very nice also. And she has a mastery and command over the fetal medicine. We have been interacting with each other. For as an obstetrician, I'm always in dilemma about what to do about fetal medicine cases. She's been guiding me through all these things. She's the director of fetal medicine unit at Defects Hospital, Amravati, a young enthusiastic person who has a postdoctoral fellowship in fetal medicine at Mediscan, Chennai, and at present fully involved in fetal medicine. To the stage you are starting.
Thank you so much. I would like to share my screen. One second. Thank you all the chairpersons.
Sir, I would also like to say that Jagruti has been a very sweet junior as well as MBBS at Somaya.
Yes, Monica ma'am is my senior.
Still remember biostatistics, Jagruti.
Yes. I thank, and it's a pleasure to be here. Thank you so much, Sunita ma'am, Vinita ma'am, Kiran sir, Monica ma'am, and Supriya ma'am. Thank you so much. Thank you all the chairpersons. And I'm very happy, and it's my pleasure to be part of the Smile Trains. I thank entire Maha Smile team also, the support team. Okay, can my screen is seen? Okay, yeah, I think once again.
Yes, ma'am. It is visible.
Okay. Yes, good evening, everyone. Today I'm going to speak on the prenatal diagnosis of cleft lip and palate. Cleft lip and palate, it is the most common abnormality of the fetal face with an incidence of 1:700 to 1:1000 cases. It has a high prenatal detection rate, of course, in the expert hands. And as we all know, the upper lip evaluation is very important, and it is a part of anomaly scan detection. Now, coming to the defects of the upper lip and the alveolar ridge, they can be diagnosed prenatally within relative ease. But the diagnosis of abnormalities of the secondary palate is challenging. Though cleft lip and palate can occur in isolation, associations around with 100 different chromosomal abnormalities have been documented, and over 400 syndromes are reported to include the isolated cleft palate. Cleft palate is a category most frequently associated with additional congenital anomalies, with the reported prevalence of associated malformations ranging from around 22 to 78%. Structural anomalies tend to be more frequent in the fetuses with bilateral cleft than those with the unilateral cleft. Chromosomal anomalies also are highest in the fetus with median facial clefts. Again, the risk of recurrence is also a major concern. So families with the one child with cleft lip, with or without cleft palate, have a 3 to 5% chance of a recurrence. And if both a parent and a child are affected, the recurrence rate may be as high as 15%. So obviously, hence an effective screening method for detecting cleft lip and palate is needed, particularly that can be applied early in pregnancy, as early as first trimester, and when it is possible to perform early genetic diagnostic tests. So let us see how do we actually do the ultrasound prenatal evaluation of the fetal face. So first we'll look into the ISWAC guidelines. ISWAC guidelines gives the performance of the routine mid-trimester fetal ultrasound, in which it says for the face, Evaluation of the coronal view of the upper lip, nose and the nostrils is important. Then both orbits, both lens and median facial profile. This is for the face. So minimum evaluation of the fetal face should include an attempt to visualize the upper lip of the cleft anomaly, if possible for the cleft anomaly, and if technically feasible, other features that can be assessed include median facial profile, orbits, nose and the nostrils. So this is showing the nose and the mouth section. So this is the nose, this is upper lip, lower lip, this is the median facial profile, and these are the orbits in the axial section. So to how to go about this during a scan. So from the transventricular plane, which you see here, we need to slide the probe a little down and then rotate towards the face to get a coronal view of the upper lip, nose and the nostril. So this will look like something like this. Again, this is a nose, nostrils with the philtrum in between. This is the anterior, this is the lip, upper lip and the lower lip. Mind, it is very important that there should be an adequate amount of fluid surrounding these areas, and if at all, and the best if it is in the mouth also. If the fetus opens the mouth, it is more easily seen. Then coming to the face profile, again from the transventricular plane, sliding little down and then rotating the probe 90 degrees, we get the median facial profile. Again in the face, we look for the forehead, the nose, the nasal bone, the lips, and the upper and the lower lip, and this is the mandible, and this is a palate. We will talk about the palate in detail. So again, just revising the normal findings with the rule of 3 that we follow is look for the facial profile, look for the nose and lips, and the retronasal triangle is also included, which is also called as a premaxillary triangle or a PMT. So facial profile is looked for, you look for nose and mouth, and also a little posterior to the nose and mouth, you get a premaxillary triangle, which is a bony area, like the two dots here. The apex is formed by the nasal bone, while the base is formed by the premaxilla, and you have these two dots. These are the mandibular processes. Let us understand how do you look for the different types of cleft lips. Now you know how. Now we know that how we look for nose and lips. So this is a median cleft lip. Like suppose if you have a median defect in the center, the upper lip is defective in the center, this is a median cleft lip. If you have both the sides there is a defect and the upper lip is divided into 3 parts like this, it is a bilateral cleft lip. And if at all it is only on the one side here like this, this is the upper lip and here the defect is here, so it is a unilateral cleft lip. Looking for the palate is very important. So just beyond, as we have seen the nose and lip part, just posterior to this section is the PMT view. Now this is a complete PMT which is seen, but if there is a defect like this, then we need to suspect a cleft palate also. Obviously, and 3D and 4D evaluation is of importance. Once we have diagnosed, we can confirm our diagnosis with 3D views. And it not only that, but it can also help us to counsel the patient, show them that this is the defect. While counseling, during the counseling sessions, we can show this to the patient that this is how the baby is going to look. Coming to some theory, like this is a paper, this is a recent paper by our own SR Lakshmi madam and her team. They have spoken about an absent superimposed line sign, which is a novel marker in an early diagnosis of the cleft of the secondary palate, very important. So they said that the superimposed line sign is a new sonographic marker for evaluation of the cleft of the fetal secondary palate. Documentation of this sign proves the presence of both palate and vomer in the midline. Again, the most important part is that this marker can be demonstrated early in the first trimester, allowing the early diagnosis of the secondary palatine clefts. So let us understand this with a picture diagram. So this is alveolar ridge. This is in the axial plane that is shown, and this is the secondary palate. And this is in the mid-sagittal section. You can see this is a nasal bone, this is a palatine maxillary line, maxilla, and this is a vomer bone. while this is a mandible. So now in this view, if you see, the vomer bone appears as a line superimposed on the distal 2/3 of the maxillary line as the vomer fuses with the secondary palate in the midline. So this is the superimposed line sign. So you see a maxilla here and a vomer which will fuse on the secondary palate. Now suppose there is a defect in the midline and there is absent, the secondary palate is also defect. So what will it look like? If there is a midline cleft of the secondary palate, the line formed by the palate here is absent, and hence only the vomer bone is visualized, creating a single line instead of the normal superimposed double line. So there is a difference between this and this. Coming to the ultrasound pictures, now let's see and relate it in the ultrasound this thing. Now this is a normal baby showing, this is a nasal bone, this is nose, lips, and here is the maxillary line, and this is the vomer bone. So this is the superimposed line sign, very well seen. And this is the absent superimposed line sign where only the vomer bone is seen. Because the palate is absent, only vomer bone is seen. So the vomero-maxillary junction is abnormal in the fetus with a palate and cleft, and visualization of this junction aids in their detection. Now this is the normal appearance of the fetal vomero-maxillary junction showing superimposed line sign, and which can be, now this is the fetus at 13 weeks. This is a fetus at 14 weeks. 17 and 20 weeks. So definitely at any time we get a chance to look at the fetus, this is the best view to look for the palatine, secondary palate defect. So looking for the superimposed line sign will definitely diagnose the palate defects. So can we do anything in the first trimester? Yes, still more, this is also Lakshmi ma'am's paper. They have said that also the axial view has a better potential for diagnosis of palatine clefts, as this view gives an access to the direct visualization of the entire palate in the first trimester. So again, a palate can be, they say that it can be viewed better in the first trimester because of the shape of the palate actually. So why not diagnose it on time? I have taken, pulled out a few of my videos to just show how a routine evaluation of face is done, and then we talk about few abnormal cases. So this is a face view, median facial profile, where you can see this is the forehead, nose, nasal bone, nose, lips, mandible. This is the palate, and we can see the superimposed line sign very nicely. This is the vomer here. Then little rotate 90 degree, we see orbits. That's the nose and the lips. Little posteriorly, if we go, we see the PMT. And in the same play, this thing, if we go little axial, we get this mandible, maxillary line. And you can see the alveolar ridge. If there is any deficient there, then we can diagnose the cleft palate can be diagnosed. Now this is this thing with a median cleft lip and palate. As you can see, this again, this is a nasal bone, this is a mandible, but see entirety, the palate and the vomer, everything is absent. I can't see anything. So now the fetus has opened the mouth. Again, it is much clearer. So this was a median cleft lip and palate. If you want to see it again, there. The entire thing is absent. So this is definitely, Okay, coming to the first trimester, can we diagnose cleft palate? Yes, we definitely can. Now, this is a view where we look for orbits and the premaxillary triangle. Now, we have seen how the premaxillary triangle, the base should be complete and it is formed by the premaxilla. Suppose this, like here, the defect is there. So that means it is having a cleft lip. Plus, we can also see the superimposed line sign. Here, one side you can see it, but the other side it is deficient here. So again, this is in the first trimester. We can also look for the cleft palate. Another thing we need to see is whenever there is any anomaly like holoprosencephaly, again, they are associated with median cleft palate. So this was a baby with holoprosencephaly, and it is having a median cleft palate. The PMT is not well seen here. So again, that okay. So yes. Now once we have diagnosed, we need to rule out associated anomalies. As we have already seen, they are associated with a lot of syndromes also. Then invasive testing to rule out aneuploidies. If isolated, it has excellent outcomes, and we should be counseling positively. So the birth of the baby with a cleft lip or palate is emotionally distressing to the parents. With no forewarning, the psychological trauma could be considerable. An antenatal diagnosis, if supported by antenatal counseling, it definitely improves the psychosocial aspect of the cleft care. And can make
We have lost the picture.
Dr. Jagruti, you're not audible and you have stopped.
Visible also.
Yes, yes.
I think there may be some issue with the internet.
Yeah, yeah.
She must not have realized.
I'll just call her. I'll call her, ma'am. 1 second, ma'am. I'll call.
Yeah.
Okay.
On the last few slides are remaining, she's lost her internet connection. So she'll try and join back, sir. In the meantime, I request Bharat sir and Pratibha ma'am to sum up the talk and give your expert comments about it.
It was really a nice presentation. All the videos and clips were very nice. They are all the book pictures. I thank Madam for such lucid presentation. And I have one question for Madam also. Can we diagnose an isolated palate and how should we diagnose? And one question for my co-chairperson, Dr. Sudesh. Can a patient demand for a termination for an isolated cleft lip or cleft palate? And how should we proceed in that case?
I will take the second question first. If patient has an isolated cleft lip or cleft palate, we need to work out the patient for more anomalies because, as Dr. Jagruti said, the cleft lip and cleft palate is associated with many more anomalies and many chromosomal syndromes and so that. So we need to work out about that, give enough amount of information to the patient. And if any of those things are there, then obviously we may need to terminate the patient. Secondly, even if it is only a cleft lip, we should try our level best to tell the patient that this is not a condition which is going to hamper the life of the baby. It is definitely doable. It can be done. We can show few photographs which are available on the internet, or maybe we always have some child or other who is, or maybe a person of our age also who has had a cleft lip, cleft palate, and who is now 50 years old. So we can always give that example and persuade patient not to go for termination. But still, if they are very much worried and they don't want to continue the pregnancy for their cleft lip, we can always do it as a trauma to the mental health of the patient.
Thank you.
Very rightly, sir said we can give the advice for the termination, but many times we can diagnose in late pregnancy, and that time if we diagnose, we tell them previously during ANC only, and then it is very easy to convince them after birth, and they are ready. And nowadays this surgery is free. And that's why people are getting ready for that. Previously, means people like
is
us, we are
happening?
working in the rural area, and money problem is always there. And if it is free, they are again agree with us. Yes, it is
What is
free.
happening nowadays? Isolated cleft lip and cleft palate are rarely.
Yeah.
When there are associated anomalies, no doubt we are
We have to
convincing them
terminate.
that better to go for termination. I had a patient. The mother-in-law asked me, "What will you do if she is a female child? A male can hide it under mustache, but if she is a female and if I operate her, that will be problem for her. Better you go for a termination." However, I convinced her. She continued. The baby is fine now. She has been delivered. So this problem arises.
We need to counsel them positively.
Positive. Yeah. And previous diagnosis during ANC only counseling is very good. Otherwise, scenario will change.
Ma'am, we had a complete lecture on the medical legal aspects of diagnosing cleft lip and cleft palate in the last Smile Train webinar by Dr. Rajendra Tiwari, sir. We will share the entire recording. So, sir has already put an expert's opinion as well as the judgments that were passed. It is completely on to the patient to decide, because treatment modalities are available and those children live a perfectly normal life. So it is on our part how we counsel them and we give them the treatment options of, and it is thank you to Smile Train that they are there and they're doing the surgeries free of cost, so that it's not a burden on the would-be parents also. So I think if we give them an option that we will be able to handle it without giving a financial burden, most of them will accept it, sir.
Yeah.
Okay, Jagruti, there was a question before you joined for you that how will we diagnose an isolated palate, cleft palate?
Okay, palate. Yes, definitely. We should have it in the protocol. Actually, how much time is given for the scan is important. Like we say, we look for nose and lip, but we should go beyond and look for the PMT also. That is when we will get to see that the palate is deficient, and after which we do the extra further this thing. So, I mean, to whom you are sending the patient, it's very important how much time is allocated to doing a scan and what are their protocols. And obviously then go into, like, if we suspect there is something in the palate, and then we go into like the superimposed line sign, and then the secondary palate is also visualized in detail, after which again the associated anomalies have to be ruled out. So yeah, it depends. We can diagnose definitely, but we need to have that much of give time and that much so confidence, like, yes, you have to look for it to diagnose it, then only we'll get it.
Okay, thank you, ma'am.
Yeah.
The clips were very fine. That are the dream
Sorry?
clips that every clips which you showed about the fetal clips, sonography clips.
The sonography images that you showed is what sir is talking about, Jagruti.
That superimposed line sign very nicely she showed.
Yeah, it was very nicely presented.
Superimposed line sign.
That, yeah, the video, I thought, because it will be only understood through a video than the images. So I took a clip. That is a second trimester scan that I was doing, and then and by then madam has already called me to give a lecture. So I thought, why not show this, which is nicely seen. So I just capture it for the sake of this thing. So it was.
And you rightly said about how much time is given for the scan is also very important thing.
Yes, that is how. And
because
suppose
many
many
times we saw
what
reports
happens,
from very expert centers also they are missing the diagnosis.
No, sir. Many a times it is not that baby will lie down the way we want. Many a times it is not showing the face. It is not. Then we cannot just assume ki okay, nose mouth is seen, that means there is nothing. We have to wait till the baby comes in position. Ask the patient to wait. Then call her back, see again, and make sure that whatever we have seen is normal. Then only we can say that there is that the baby, unless we've seen, because then like this a lot of things can be missed. So it's very important to give good time to the patient, obviously with patience.
Thank you. Thank you, Jagrati. Thank you, Bharat sir, Sudesh sir, and Pratibha ma'am for chairing this session. Supriya ma'am, would you like to conduct?
Thank you so much for the
Would you like to
opportunity.
conduct the second session, ma'am? Supriya ma'am,
Fine,
you have to
yes,
unmute. Yes, ma'am.
sure, yeah. Okay.
Yes, ma'am.
So
Thank you.
let me invite the chairpersons for the next session. Can we have the PPT?
बेटा तुला जे आता सोनोग्राफीवर आपल्याला दिसतंय ते पूच आहे. फक्त आपण गोळ्या घेतल्यात म्हणून ते पू लाल नाही दिसत आहे तुला किंवा तुझं ताप कमी झालंय. पण ते पू अजून पूर्णपणे मऊ पण नाही झालंय की मला ते काढायचं असेल समजा.
Monica, please mute yourself. Monica.
सॉरी मॅम.
Okay, so it's a pleasure to invite the chairpersons for the next session. We have Dr. Prasad Alkarnikar, who is a private practitioner at Sneh Hospital, Kolhapur, president of KOGS Kolhapur, and he's been in private practice since last 1990, so several years, with areas of interest of infertility and vaginal surgeries. So welcome, Prasad sir.
Thank you.
Next, hello. Next, we have Dr. Sumant Kulkarni. He is MBBS MD DNB from Shivaji University, Kolhapur, consultant obstetrician and gynecologist, awarded the Young Talent Award Contact Device Siliguri, training by Dr. R. Rajan, the real boss from Kottayam, and he's done his training in IUI. He's the president of the Miraj OBGYN Society, ex-associate professor of VMMC Solapur and GMC Miraj. So welcome, sir, Dr. Sumant Kulkarni. And can we have the next slide? Yeah. We invite Dr. Sheetal Nath Kole. He, sir, is an ex-lecturer of the Vanless Hospital, Miraj and KIMS Karad, practicing as a consultant gynecologist at Isal Karanji since 2002 and president of the Isal Karanji OBGYN Society. So it's a great pleasure and honor to invite all the chairpersons. And we have a great speaker lined up, Dr. Sriram Pandit, authority on the subject. And may I introduce Dr. Prasad Halkarnikar to please introduce the speaker for today.
Thank you, Supriya Madam. Dr. Sriram Pandit is practicing at Pandit Clinic, Pune. He is professor of plastic surgery, Bharati Vidyapit Medical College, Pune. He is faculty at Sancheti Institute of Orthopedics and Rehabilitation. He is project coordinator and lead surgeon at Pune Hospital. He has done over 7,000 left children and 15,000 outpatient consultations. He has performed over 1,200 plastic surgeries in undeserved region. He is past president Maharashtra State Chapter Association of Plastic Surgeons of India. He is founder member and past president of Pune Association of Plastic Surgeons. He is executive trustee Maharashtra Association of Plastic Surgeons. He is specialized in aesthetic surgery, in facial, body contouring, and breast surgeries using advanced techniques such as laser treatments, and RF devices. He is expert in cleft lip reconstructive surgery, palate surgery, burn reconstruction, and trauma-related reconstructive procedures. He also performs non-invasive treatments like ultrasound, sonic lipolysis, body tight skin lasers for rejuvenation and pigmentation issues. Over to sir.
Thank you very much, Dr. Prasad. I'll start sharing my content. Just let me know if you see it.
Sir, it is seen now.
I'm not able
Your
to.
Your screen is seen, sir. It has not yet started with the PPT.
I think I'll rejoin the meeting. It will be easier. Give me a couple of minutes.
Yes, sir. Yes, sir.
Meanwhile, just carrying forward the discussion that we were doing previously, I would like to ask all those who are present here, especially Sudesh is here. Suppose patient insists that they want to do second trimester MTP just in view of cleft lip or cleft palate. Should we insist on a plastic surgeon or a pediatric surgeon opinion? Sudesh, are you there, or any of the experts, chairpersons, if anybody would like to opine? Sudesh? Oh, sir is
See
back.
my screen now? Can you see my screen?
Yes, sir.
Yes, sir. Yes, sir. We can see
Okay,
now.
good.
Just make it full screen, sir.
Yeah,
We can see your slides.
I am trying to do that. Give me a second.
Yes.
Can you see the screen now full? Hello?
Yes, sir. You just close this small window that is open, black one.
Yeah, one second.
Yes, sir.
Yes,
Now
sir.
it's
Yes, sir.
perfect. Yes. It's gone. It is gone. I think sir again got locked out. Sudesh, what is your opinion? Should we insist on taking a plastic surgeon or a pediatric surgeon opinion before we terminate pregnancy, even if patient is opting for it? After having counseled everything, they say, na, आता आम्हाला तरी पाडायचंय. तर is it necessary to on paper have an opinion from
No,
pediatric surgeon
See,
or plastic surgeon?
what the law says, the opinion is to be formed by two RMPs, that is gynecologists, who are given the authority to terminate the pregnancy. So the opinion by a pediatric surgeon or a plastic surgeon is not mandatory for doing a termination. But still, if you want to convince the patient more, then these people are the people who have more number of cases, who have handled actually the cases. They will have more convincing power to tell the patient that no, cleft lip of cleft palate is not a thing to be terminated, but definitely the child should be welcome. So for their positive counseling, we should do it, but by law, no, not mandatory.
Okay, okay. So it can be the patient's choice if they want to
Yeah.
do the termination.
Yeah.
Okay. I think sir has got logged out or what? No, he's there.
He is there from two devices, ma'am, I think, and he's trying to share from one of the other devices.
Okay, okay.
Yeah.
Then can the tech team help him and share the
Harsha,
slides
can you,
for him?
if you have sir's PPT, no? You
Yes.
can share it from your end.
Okay, okay. I'll just do it.
Srirang sir, can you share the PPT with the technical team?
I'm trying to get back on.
Yes, sir.
One second. Yeah. Sorry for the mess.
In the meantime, ma'am, let's discuss about the feeding issues that we face in a baby with cleft lip, cleft palate post-delivery, and how do we think as obstetricians we should counsel the mother regarding the feeding practices? Because there will be a lot of regurgitation and loss of weight gain, and the pediatric surgeon will say, "नहीं नहीं थोड़ा 1.5 kilo और बढ़ने दो फिर आके we will operate." So if anybody has any take on how we will counsel the mother to feed the child. So this sir, let's start with you only, sir. Nobody else is speaking.
Really, feeding the baby is a difficult task. We have to take help of the breastfeeding counselors, the pediatricians, or maybe a mother who has fed the child, a mother of a affected child, previously affected child. She could be the best person to convince the mother कि ये करना, ऐसा करना है, वैसा करना है. Because see, we as clinicians, we know we can tell a lot of things, but it is actually the mother of the affected baby who has to go through that pain and seeing the baby regurgitating again and again, coming for not growing very well up, and the surgeons wanting to the baby gaining the weight. So that time we have to counsel them. There are a few issues which need to be addressed, and the breastfeeding counselor could be of great help in these things.
Can you see the screen now?
Yes, sir.
Yes, sir.
Full
Yes, sir.
screen?
Yes, sir.
Yes.
Hello?
Yes, sir.
So it is seen now.
Okay, good. Thank you.
Yeah.
We'll start, right?
Yes, sir.
Yeah. So I did my first cleft palate assisting with my professor, Dr. Guleria, and that was in 1977. So for last 47 years, I am into doing lips and palates all the time. And with the opportunity that Smile Train has provided, we were able to build on this experience and expertise to make them a much better results that we can give to our patients. My greetings to you from Pune Hospital, where we run the Smile Train program. We started in May 2002, and we have almost very close to 10,000 surgeries. I'm very happy to say that we have had a fantastic time over the last 25 years trying to help children, and it's a big privilege to be able to do that all the time. My team seeks your blessings for our young special children, because we need all the good wishes that come our way so that we can make them like normal citizens of our country. That's me. Cleft palate is lip and palate is a multifaceted, complex deformity. And one of the problems with it is evolves with time. It is not like an appendix which is diseased, you remove it and you are done with it. As the child grows, the deformity also grows. And what I do on the third month is going to be with the patient all his life. So I have to be very careful in choosing the treatment, and also use good expertise to possibly produce the best result that you can do. Sometimes we have to work with the children till they are adults. So the treatment span is when you, at the 3 months, you do the cleft lip repair, and at the age of 30 years, you might have to do a rhinoplasty to make them look normal. We need a very strong and dedicated team to see them through. Teams are of 3 types. There is medical management, administrative management, and most important is funding. And with Smile Train, we have taken out the funding equation completely. We have at our disposal the best equipment, best anesthesia, best hospitals to do whatever we want to do for the best of the patient. The man who is standing in the center is Mr. Charles Wong, and he is the principal person who is responsible for getting Smile Train to what it is today. He is no more with us now, but his legacy will live for years and years and years. This is my team at Pune Hospital, Dr. Gandhi on my right, and my son Vikram Pandit on my left. And 3 of us, we almost operate every single day at the hospital. And we are very happy to continue this work for last several years. That's our OPD. And the next most strongest pillars of our strength are our anesthetists. And I must say that we have got a fantastic team of anesthetists who work with us for last several years. They're really, really good, because the lip and palate is a very difficult problem. Intubation can be extremely tricky, and sometimes a bad judgment can lead to death of the patient. So this is Dr. Janvi Thatte. She is one of our pillars of strength. We have teams which help us with us, the sisters and the nurses. They are actually the backbone of the team, because they are they do, and they give a good benefit to the patient. So this is Dr. Mutha, who is also a very good anesthetist, and he is carrying a baby into the operating room with all the affection and care. And you can see the same child with the result that you can have post-operatively. It is very important to have a very good result at the first time, because that is the impact the patient's family is going to carry. And if your first result is good, they will keep coming to you for the rest of their lives. That's the hospital administration helping us again. And this is something very important. This is the plug that we got when we finished 5,000 cases. All this time, Smile Train team was there with us. And in the man in the center, the tall man, is Mr. Bajaj. And he's he owns Bajaj Finserv and Bajaj Finance, and he has taken it as a CSR initiative to take this project to a logical, good completion. So we are grateful for the assistance that is offered by Bajaj Finserv Group, and we had a unofficial meeting when we discussed all the problems that we face, and he was very, very, very outgoing and ready to help at all points of time. We have a powerful team which comes from Smile Train. This is Susanna Schaefer, who is the manager. Then we have our regional manager, and we have Leela Imam, who is a project coordinator in many places. My team now brings invaluable expertise to our program, and we are now able to provide every single type of surgery, right from the lip repair to orthodontic surgery to our patients. Most important, it is completely, totally free. The patient doesn't have to spend one single rupee to get the treatment that they deserve. The treatment is, of course, world-class because the infrastructure and the expertise is now very, very difficult to reproduce anywhere else. The anomaly scan, as you saw, it was a brilliant presentation, and I learned so much from the ultrasonic diagnosis that was done, and the scans and the pictures, and I got enormous information from that. So you can see them like this. You've already seen them, nothing much to show here. The impact of the diagnosis, which is made prenatally, is also very important because they want to know whether they should continue the pregnancy or have a termination. And sometimes the ultrasoundologist will be the first person to bring the news to the parents of the anxious baby. The prevalence of the facial clefts is reported at about 6 per 1,000 live births, which in itself is quite a large number. They can be of various types. It can be a complete cleft with nasal deformity. It can be only a notch in the lip. It can be a severe bilateral cleft lip deformity with projecting prolabium, projecting columella, and absence columella in that nose. Another cleft lip bilateral, and this is how the result is immediately after surgery. It takes about an hour and a half to bring the child to this level. This is unilateral cleft lip repaired, and you can see the kind of change that you can bring to the child's face. So for the mother, it's one of the most stunning developments in the child's life program. These are one of the worst types of clefts that you can get. You can see this child has about 11 clefts. There was a cleft in the eyebrow, cleft in the upper lip, cleft in the lower lip, bilateral lip cleft, maxillary cleft, and she had a very wide cleft palate also. She did not get any treatment for so many years. She's now almost 8 years old. And the problem was nobody was willing to touch her because they didn't know what kind of surgery to offer and whether it will be possible to do when there is no financial help available to her. Her only desire was to be able to eat a laddu because otherwise, whenever she used to start eating, the food used to pop out of her mouth. So that is what she is now, a very smiling, pleasant girl, and she is enjoying her studies and her life now. We did about 7 surgeries for her in one go because she lives in Buldana and it was very difficult to call her repeatedly for surgeries again and again. So with the help of our brilliant anesthetist, we decided to take on a very long surgical procedure. It took about 3.5 hours, but we could repair almost everything on her face with one go. She can be made much, much better from this point on, but she is not interested. And we have, in fact, offered her twice. We, in fact, give them their travel money also, but she hasn't come yet for revision procedures. But this is something very satisfying, and you feel you've done some good to the society. Another child with really multiple deformities. There is every possible structure is cleft. And there was a time where we used to think that we can't really offer anything to these babies. But with the modern help, the good anesthesia, you can do this kind of repairs in one go. Again, multiple repairs done at one time. This is all possible because we have enormous help from Smile Train. They have never stopped us from doing what we want to do. And that's why these kind of results can produce all the time. This is a patient with a nasal cleft. And this is after the repair, almost near normal restoration of the nose. And this is very important because these are millimeter precision surgeries. And if you don't do them right, then you will have a problem for the rest of the life. First time is the best time. And if you get that chance to operate, please see to it they get the best outcome. That's a lateral view of the same patient. You can have median clefts like this. You can have a median cleft like this. The nose is split completely. And this is, when he has grown up now, he is now 23 years old. So he has been with us all throughout our program. This is one of the brightest pair of eyes I have seen in my practice. Such a beautiful child, but this is what is a proboscis. And you can get deformities of really a very, very large spectrum of deformities can be there together. So the diagnosis of cleft lip is very, very obvious because you see it. The cleft time sometimes is missed because unless you really carefully inspect inside, and especially when they have submucous cleft palate, it is difficult to know the palate is cleft during examination. Once you've seen the deformity, the next questions are very, very clear. When to operate, where to operate, and how much it will cost. Because this is what is going to decide whether they go to Sassoon Hospital or they go to a private clinic or they go to Bombay or they go to a foreign country to get treated. The Smile Train has fortunately taken out the cost equation completely. We don't have to worry at all about whether it will be affordable or not. Every single kind of treatment for cleft lip palate is now available with us, which comes to no cost to the patient. A full-blown cleft lip and cleft palate deformity requires several surgical procedures. There will be lip repair, there will be palate repair, there will be alveolar bone grafting, and there will be rhinoplasty. So minimum of 4 procedures will be required to get them to some kind of normalcy. The repair of cleft lip is one of the most dramatic surgical transformations. It is critically important to understand that the lip is a very complex structure, and our aim is not just plugging a hole, but trying to make a new lip which will look normal and function normally for the baby. If you look at these two pictures, you will see the kind of anatomical changes that occur in 1 centimeter area. There are alveolar ridges, there is vermilion, there is white roll, there are so many structures. And unless they are in the right place, you will not get the best of outcomes. And that's where the skill lies. It's a 45-minute procedure, and if well executed, transform the life of the baby and the family for more days than one. The mother generally feels that she is guilty and responsible because she has produced a child which is deformed. And that has an immense psychological stress, and when she sees the repaired child, she's justifiably overjoyed. Then it comes to logic that why not do it earlier? Why not do it? Why wait for 3 months? Why wait for 4 months? The question is that if you operate very early, there are a lot of experiments have been done in intrauterine repair. You take out the baby, repair and put it back, and then deliver the child, and the mother never sees the baby with a cleft lip. But those are heroic attempts and not for everybody to do. The results are generally very poor. So it is much better to wait for some time and then do the procedure and expect a good outcome. Anesthesia in young children is very risky. The tissue demarcation is not clear, and the alignment can go very wrong. At 4 months, which is our standard operating time, anesthesia is safe, much safer. The child has grown a little more, and the post-operative care is easy too. The aims of cleft lip repair is very, very obvious. You want to restore aesthetic and functional normalcy. When you repair the lip, it will also act as a restraining model to maxillary growth. So we time it between 3 to 4 months of age. The standard rule of 10 grams of hemoglobin, 5 kilos of weight, and no respiratory infection, and a healthy, thriving baby is all that we want to treat a cleft lip child. That's the golden rule: 10 grams hemoglobin, 10 weeks of age, and 10 pounds of weight. If you have an experienced surgeon, it always makes a big, big difference. The anesthesiologist must be experienced in cleft anesthesia. Sometimes the intubation can be so tricky that fatalities have occurred, and they keep occurring even now. But we must have a good anesthesiologist who will be able to deliver the goods. Good operating rooms, good equipment goes without saying. because we are sharing the airway, top class post-operative care is mandatory. So you must have a good nursing team which will look after these babies later on. The child normally started on oral feeds, and by the time it is wide awake, which is usually 2 hours, the first few feeds are under supervision. IV line is kept for 24 hours, but no IV fluids are required. The blood loss in a well-executed lip is generally 5 to 10 ml, and the child is nursed in the ward for 24 hours and then discharged. That's the suture we use. The impact of both physical and psychological is really, really awesome. And this is why is one fine result that I want to share with you. The parents did not believe that it is their own child. It was so much of a change from a defective lip and a defective face to a near normal looking lip. The nose has come perfect, the lip is perfect, the Cupid's bow is perfect. And this is what we want to strive and want to achieve every single time, though it doesn't happen. But this is what our target is. Another baby with a severe bilateral and cleft lip and palate deformity. You can see she had no columella, she had no bilateral lip, palate, and everything. She had badly growing teeth. And this is how she is a 10-year-old girl now, going to school, studying well. And these are, some of them are really brilliant children. 2 of my patients are now maxillofacial surgeons. One is practicing in Australia, one is practicing in India. And there are many, many of them who have done very, very well in their lives. By no means they are of poor quality product. They are good, they are intelligent. And we can do so much for them that they can lead normal lives. Another baby with a cleft lip, that's a post-operative. Little later, another baby, smiling, nice baby. They have one of the best smiles that you can ever see. That's repaired. And you can see the scar is practically invisible. If you do it well, the scar will be hardly noticeable. So this is one of the child which we have been treating since 2005. Complete cleft of the lip and palate on the left side. This is due the day of surgery. This is after the lip was repaired. This is a few days before when she came for palate repair. This is few days when we revised the lip to make it look still better. And this is how she is, a grown-up young girl, very, very happy, and had no difference whatsoever in her moving around in the society. And this is what we want. We want smiling, happy children who lead their lives to perfect normalcy. The next repair comes is the repair of the palate, which is a much more involved procedure. This is the cleft, unilateral cleft palate. It can be unilateral, it can be bilateral, it can come in various sizes and shapes. The surgery is generally between 10 months to 18 months of age, and because that's optimal time for cleft palate repair. The child normally starts speaking at 10 months of age, starts making sound. So the logic is that you repair the speech apparatus before the child starts learning. If you delay too much, the repair may be very good, but the child has learned to speak in a faulty fashion. And sometimes it is very difficult to take out of the child's head. The speech outcomes deteriorate significantly after the surgery is delayed beyond 18 months of age. When you do the palate repair, it separates the nasal cavity from the oral cavity. It helps speech and prevents food from entering the nose, and it also prevents nasal secretions from going into the oral cavity regularly. So this is a typical cleft palate repair. And you can see you have to take relaxing incisions on the side of the palate, move the palate medially, and repair it completely. Surgical time is about 1 to 1.5 hours, and the blood loss can be up to 20 ml, which is quite easily manageable. It is very important to repair the muscles of the palate, and that gives you much, much better speech results. And here in this picture, you can see that the muscle on the left side is quite well united. The tensor palati, the levator palati, palatopharyngeus, palatoglossus, they're all carefully sutured to each other. And that will give a much finer speech result than otherwise. It needs little more post-operative monitoring due to possible bleeding in the oral cavity. Because if the bleeding occurs in the oral cavity, re-anesthetizing the baby is very, very, very tricky. And sometimes the clots can cause respiratory embarrassment. So we normally keep them in the OT recovery room for 4 hours. And once they are stable, had milk, then they are shifted back to the ward. In what is called a Pierre-Robin syndrome or a Robin sequence, sometimes it's very difficult because to intubate the children, and we have 3-4 times abandoned the procedure because intubation could not be done even with a fiber optic laryngoscope. It's very important again to know that all surgical exercises are only possible if the children are well nourished, healthy, and free of respiratory infection. Nutrition plays a very major role, and now the Bajaj Group has started a sort of campaign to make it very easy for the children to be getting the food, getting the milk, getting the formula that they need to build up the child at a regular basis. So these are some results that we are very happy with. These are all cleft lips repaired by us over last many years. And this is what our target is, a smiling, happy baby, which is coming into life with all its forces. So thank you so much for the patient hearing. And I apologize for the mess that I created at the beginning. I hope finally it did work well. Thank you. Was I audible?
Yes, sir. Kole sir and Suman sir, over to you for your expert comments and feedback for the lecture.
Very nice and informative slides, Dr. Pandit sir. A noble work what you are doing is really admirable. From this particular slide, I do remember few memories of my residency when we had an allied post in Department of Surgery when I was doing my gynec posting.
Okay.
And one of our plastic surgeon, Dr. Avinash Patil, who is also having his center recognized for Smile Clinic.
I know.
And
I know him very well.
Yeah. And most of the surgery residents were not willing to assist him because they want to go for their regular work. And I being an allied post, I was used to assist him. And I know what pleasure I am getting when I see the results of the babies coming out. Yes.
So nice of you to help.
Yeah, sir. The rule of 10, I think what you have really explained, that is the weight of the baby should be more than 10 pounds.
Yes.
Hemoglobin should be more than 10 gram%. The WBC count should be less than 10,000.
Yeah.
And the age of the baby should be more than 10 weeks. I think these are the important parameters that one should keep in mind.
Yes.
And the results what the parents, they look when they get the baby at the hands of obstetricians first.
It's amazing.
And they look at that particular cleft palate baby, they get really shocked. But when we convince them and when we send these particular babies for the repair, and when they come out with the repaired babies, the joy on their face is really admirable. So we really give a hats off to all you people because you're doing a really admirable work for this particular thing. Thank you, sir. Nice. Thank you.
Thank you. Pleasure.
Thank you, Suman sir. Thank you, Kole sir, for chairing this session. And thank you, Pandit sir, for throwing light on such an important issue of actual management of the patients in the post-op periods. We now have some questions for Dr. Jagruti Murke, which have come in the chat box. If we have the time, can we discuss it, Harsha? Do we have the time?
Yes, ma'am. We can.
The first question is, what advanced ultrasound techniques can improve the detection of cleft lip and palate in utero?
Yes, definitely there are advanced this thing, but I believe the 2D, the basic 2D scanning is most important. Then we go into the details and see, but to suspect, whenever we are scanning, we won't be knowing that there is something wrong. So when in general we are looking for the baby and looking for the other anomalies, your protocol should be fixed that we have to look for these things. So once we get into something that is not to be seen, and that is when we went to go into the details of the things, like we want to do a 3D scan or all that. So 3D does help to look into the other sections like mid-axial sections and all, but the primary thing that we need to do a good 2D with a good baby position And I think that helps the most. And how much time you're giving, again, I'm saying you need to give good time to the scan. The anomaly scan needs to be done well with all our list being taken care of. It's not only the face, it is also the heart, the other part of the baby, and the baby won't be in the the position you want always. So always wait for a good position, see and make sure that what you're looking for is normal, and then go ahead for the other parts, I guess. So
The second question was how.
nothing newer things. Is basic thing also, if you do it, it is good to diagnose. As we saw on 2D only, we can see the secondary palate and all that, which I have explained. So it's not much of a very advanced thing.
The second question we've already discussed is how we would counsel a pregnant woman who has been just diagnosed with cleft lip or cleft palate on the ultrasound. So that we've already covered.
Here
And the
I
second,
would do a 3D view and show them, because a patient won't understand what these 2D gray and black things. So for the patient, we can always show them that how it would look. And definitely a antenatal counseling with a surgeon would be a good idea, so that they know how the things are going to go after delivery, what care they will need to do, and when. Also the cost, like how much. I mean, sir is there, definitely it's free of cost, but wherever they should know how much they are going to go through, what all things they will have to be ready for.
Thank you, Jagriti. There's one more question for Dr. Pandit sir. So what are the potential complications that we would expect in a baby which we have not operated?
If you do not it depends on what defect you begin with. If it's a complete cleft lip and palate, that's what we will assume. The teeth will go in a crooked fashion. The speech will be nasal, completely nasal, because the air will keep on escaping from the nose. There will be gross deformity of the nose. The nose will be deviated on one side. And these are structural anomalies which will be there in the children if you do not operate. We have, in the initial days of our smile train, we were operating on, at the oldest I operated 62 years old. He never had treatment, and there was a fear that he is blessed with some goddess. And if you repair the lip, then probably he will be in more trouble than he already was in. So we have a fairly large experience of treating grown-up people who have had no treatment in their childhood. Some of them do extremely well, even patients whose speech was very bad, and we don't expect it to be good after 18 months of age. Operating at 21 years, 22 years, 25 years, some of them develop such good speech that we really can't explain how that happens. But this will be the main thing that the growth of the face will be completely disoriented. The maxilla will keep retarded, the lower jaw will keep projecting. It basically depends on what level of deformity you start with.
Thank you. And sir, how long is the post-operative follow-up care of these patients? And what is the ideal that we expect when they should come back to you, and how frequently?
If the lip repair, like I said, we do at 4 months of age. The follow-up will be first week. At the end of 1 week, we'll call him back for stitch removal. After that, we see the child after 3 months later. Then the next surgery will be at cleft palate. Cleft palate, we keep them 1 day longer sometimes in the hospital, because complications like bleeding can occur even when they go home. Once they go back, then they can put things in their mouth like pencils, your keys, and that can injure and sometimes cause bleeding. So that is one thing that we want to look for. They also come back after 1 week for the first follow-up. After that, the next follow-up for 3 months. As they grow up, we want to see how their speech is. So normally we'll be calling them at 3 years of age, where we'll see what kind of speech the child is developing. Younger than that, it is very difficult to analyze the speech because they just don't cooperate. So when they are a little older, we get them a speech assessment done. We see if there are any articulatory errors, or we see if they have any speech nasality. We give them speech therapy if it is required. Now we have got a very good facility where even the speech therapist does it online. So they don't have to come to Pune hospital every time for regular training sessions. So that is the speech at the age of 9 years, is the time when you repair the alveolus. because the bone cannot be stitched together. You can bring it by just stitches and hold it. So the body gap is closed when the child is about 9 years to 10 years old. So that is the third surgery that you require. We normally use the bone graft from the iliac crest and put plenty of cancellous bone there. Once that job gets united in a bony way, then you can do procedures to pull it forward, because there are some deformities that develop because of the surgeries which have been done in the previous years. So it's a fairly complex way of managing them. Sometimes they do have to come, especially for dental treatment. We do a lot of orthodontics for them to get the teeth in good orientation. In the cleft, the teeth that develop sometimes can be small, sometimes crooked, sometimes rotated. So once the milk teeth fall off, then we try to reorient the teeth in proper fashion so that they get a good outcome. The final surgeries are done when they are about 18, 19 years old, which is done for the nose. And the day one, nobody knows how the child is going to look after 15 years or 20 years. So as the development after repair is complete, we do the rhinoplasty at the age of 16 years for females and between 18 to 20 years for male patients. The children who don't develop the jaws properly, because this itself is a very complex deficiency deformity. There is deficient palate, there is deficient lip, there is deficient muscle, there is deficient bone. So the growth also is not exactly the way you expect in a normal child. So they require what is called as orthognathic surgery, where you can change the orientation of the mandible and the maxilla. The mandible, if it is protruding, it is retracted back. If the jaw has gone inside, it is brought forward. And that's called orthognathic surgery. And that is probably the end of surgical exercises that are required for these patients. So it's a fairly complex follow-up depending on what kind of deformity you start with.
Thank you, sir. In both of your experience, have you found any genetic consideration for cleft lip or cleft palate? Is what our delegates want to know.
There is definitely increased incidence of, like she had said very nicely, she had presented the incidence of cleft lip and palate increases if you have one parent with cleft, then the child, about 15% chance that the next generation child will have a cleft lip or palate. Most of the patients that we find currently, there is no family history whatsoever. So, I mean, if I see 100 children in a year, probably one or two will have some relative, where not really close relative also, who had a cleft or something. But otherwise, very, very difficult to exactly pinpoint. The problem comes for me when I counsel is when they have a first child which has had a cleft already. And then they say whether should we go in for a second child or we should not. And that is something which is very, very difficult to predict. And the way the diagnosis now with such beautiful ultrasonic results, if you get it, because it's a very long process of getting the child from day 1 to year 20. And some of them are just not ready to do the same thing over again for the next baby. And I don't really blame them, because whatever said and done, whatever financial help that you get from NGOs and from us, it is still for the patient to come to hospital every time. They have to come, they have to stay in Pune for some time. And even if you have all the financial help available, it is not easy to look after a child with cleft lip and palate. So counseling them whether they should have a second child is something which I have not been able to do really well. I must accept that.
Thank you, sir. Thank you so much.
Yeah.
I think we should call for the day. And with proposing the official vote of thanks, I would like to thank Smile Train and Science Integra for hosting us on an official platform with the MOGS and the Foxy Public Awareness Committee. I would like to thank our chief guest, Dr. Sunita Tandulwalkar madam, our guest of honor, Dr. Vinita Singh ma'am, Dr. Suvarna madam, and Kiran sir, who have consented us to be present here, but due to some emergencies, both of them could not attend. Our co-convener, Dr. Supriya Arwari madam, for her constant support and encouragement. Our chairpersons, Dr. Sudesh Doshi sir, Dr. Pratibha madam, Dr. Prasad sir, Dr. Bharat Pawar sir, Dr. Suman sir, and Dr. Sheetalnath Pole sir, for your esteemed presence. It is always a moment of pride to associate with all the amongst societies. Our speakers today have done their jobs brilliantly. Thank you, Dr. Jagruti and Dr. Srirang Pandit sir, for discussing such a very important topic and enlightening us so that we would be able to counsel our patients much better. Thank you so much, all the delegates, for joining us. And thank you, Harsha, for
Yes.
being the backbone for this webinar.
Thank you, everybody.
I want to
Thank you.
thank
Thank you,
Dr.
Monica.
Monica ma'am for their meticulous planning and execution of the webinar, and our speaker Dr. Jagruti ma'am and Dr. Srirang sir. Thank you for your presentation. Your contribution to this webinar was invaluable. And also I would like to thank everyone who attended and contributed to make this event a very successful. So thank you everyone for your presence. It was a really very great webinar.
Thank you.
Thank you.
Thank you.
Thank you.